Okay, there's a Lauren on the screen that just says Lauren. Is that Lauren Reitler, or is that another Lauren? And oh, great. Okay, she's here. Just transferring the audio. All right. Well, we could just chit chat a little bit while Lauren gets connected. I won't do the formal intro yet because I'm not sure if I guess Lauren can hear me. Lauren, can you hear? You must, because you typed into the chat, right? All right. Well, then I'll do the spiel because we got a couple minutes here to get excuse me, get settled, and oh boy. It's been a long day of meetings, so my apologies. But I will do my best here. All right.
I'm seeing some alums. Bree Shantz is here.
I know. I think I saw Sydney Greenspan. Are you on here too?
I'm reading through all the names here. Oh, this is so fun.
There's Lauren. We see her face now. I know, it's so amazing to see these names on here and to have such a great turnout. We really appreciate it. So welcome everybody. I know for many of you, you've been to a lot in the series, so you hear me say the same thing. With a little twist, a little different twist each time, but we do have new folks, so I want to do our official welcome. We are so happy to welcome everybody tonight to, oh my gosh, I lost track of weeks now. 6, maybe the 6th, 5th, I don't know, a while. Yeah, 6, was that it? Yeah. 7, I can't count fingers. 7, I don't know. It's like a lot. We have been having an amazing run so far of this inaugural alumni speaker series. Oh, it looks like Lauren is still working that connection. Okay. And we've had a range of topics already, a few sort of threaded topics related to home modifications and accessibility and home safety from a few different perspectives, from everything from the nonprofit world to working for insurance companies. We have heard exciting entrepreneurial ideas. We've heard about working across languages and with interpreters. And tonight we are welcoming Lauren Reitler, who is going to be talking about her experiences in the ICU with early delirium management. We're so excited to hear that. But before we do the official introductions, I wanted to give a bit of history about how this all got started. We value our alumni community so much as, as our current faculty and our students. We know that our alums are our ambassadors. They're out there showing the world what an ICOT education and experience does. And they're making differences in all of their various practice areas. They're leaders, they're innovators. And it's so exciting to have an opportunity to be able to welcome them back in this way, and for our students to get to benefit from learning from them, and for our current students to think, wow, in just a few years, this will be you, being able to, give back to our current students and keep those connections really strong. As an alum myself, I have a true affinity for deepening our connections with our alums and really fully engaging and helping us to hear the wonderful things that they're doing, continue to support them, and again, connect our current students with our alums for that really strong network. So this series sort of got sparked by an idea from Emma and Julia, who are on the top of my screen, not sure where they are for you, but 2 amazing OT juniors who in their fall coursework started to hear about some broad aspects of occupational therapy and really got interested in innovative and emerging non-traditional practice, and thinking that how there's so much about OT that we can't possibly learn it all in our curriculum. So are there other interesting ways that we can bring this content to our students to help them learn about some of these broader experiences, maybe that are a little bit beyond entry-level practice? So they reached out to Jenna, who then in turn reached out to me, and the 4 of us got together and kind of combined their vision with the departmental vision and desires, again, to deepen those connections with alumni. And out of that was born this series. And we're so excited, and we will continue it next year. The fact that we have Zoom capabilities now allows us to connect with alums in places that we otherwise wouldn't, in people in different time zones and folks in different countries and different parts of the United States. So it's really been able to bring us together, which is amazing. And it goes to show you that, a small idea can turn into something really big and really meaningful and impactful. And we're so proud of Julia and Emma for their vision and their hard work in making this happen. They do so much work behind the scenes each week to get this lifted. So we're grateful for them. So I'm going to turn it over actually to Emma, who is going to be our moderator for this evening. But again, I want to say welcome. I know, and she and Julia are amazing with their moderation skills. They've been great. So I'm turning over in good hands. We are so grateful for you to be here. Lauren, Emma is going to introduce you, but it's wonderful to see you. Thank you for coming. And yeah, welcome everybody. Thanks.
Hi everyone, thanks so much for being here and for all the kind words. I hope if it's warm where you are today, like it was in Ithaca, you were able to get some time outdoors and be in nature a little bit. I think we all need it. I'll start off with some accessibility information first. For closed captioning and a live transcript, you can click on CC Live Transcript at the bottom of your Zoom window, which should be next to your reactions button. You have one option to show subtitles, which will make captioning appear at the bottom of your screen. And to turn off those closed captioning captions, you can click on CC Live Transcript again and then hide subtitle. Or if you want to view a full scrolling transcript, you can click View Full Transcript, which will make the live transcript appear on the side of the Zoom window. If you want to simultaneously view the transcript and the chat feature, if you go to the top of the live transcript window and click on the downward facing caret, or Karen, as Jenna let us all know that they're called, and then click pop out, you can move the live transcript anywhere on your screen. For the chat feature, the chat's at the bottom of the Zoom window next to the participants button, similar to the live transcript. If you click on the chat button and then the caret at the top of the chat window, you can choose to pop out the chat and move that anywhere around your screen. You're more than welcome to use the chat feature throughout the presentation. During the question and answer period, we'll be fielding questions from the audience through video, audio, and chat, so feel free to engage with the technology, which in whatever way feels best for you, most comfortable for you. This session will be recorded and along with an edited full transcript, and that will all be posted to the virtual OT site for current students, faculty, and staff to access. If we have any alums on the call that need it, contact us and we can figure out a way to get it to you as well. So this evening is our 6th session, so we figured out what number. It's our 6th session of the inaugural ICOT Alumni Speaker Series. And today we have the pleasure of hearing Lauren Reitler discuss her experience in the area of delirium management in the ICU. Lauren Reitler graduated in 2017 with her BS and 2018 from MS, 2018 her MS from Ithaca College. She's finishing her last semester at Baylor University, pursuing her clinical doctorate in occupational therapy with plans to graduate in May. Congratulations. Lauren has been working at Lehigh Valley Hospital, Cedar Crest for the past 2 years and spends most of her time in the medical surgical intensive care unit. Within her time in the MS ICU, she has secured a grant for her department to receive various communication devices, such as communication boards and switches. Most recently, she's in the process of obtaining IRB approval to complete a retrospective study on patients in the MS ICU diagnosed with COVID-19 requiring ventilator support. She is also completing a case study evaluating the effects of early ADL engagement as a delirium management strategy for an individual diagnosed with COVID-19 requiring ventilator support. Lauren will start us off with an overview of her work and experiences, and this will then be followed by a question and answer period where the audience will have a chance to chat directly with Lauren and ask any questions you might have. We envision this as an informal conversation and an opportunity to engage with our fabulous alumni, so feel free to ask any questions. Lauren, thank you so much for being part of this Alumni Speaker Series, and without further ado, I will turn it over to you.
Thank you guys so much. Can everyone hear me okay? Okay. Thank you guys for having me. I'm so excited to be able to kind of share my experiences, and I'm so passionate about OT in the ICU, so I'm excited to share that. I figured I'd start with just a little bit about me and where I work, and kind of a bit about the hospital where I work. So I live in northeastern Pennsylvania in like the Lehigh Valley, Allentown area. I live with my chocolate lab Banjo, and I work at Lehigh Valley Cedar Crest, which is a level 1 trauma hospital. And it's very large. It's close to 900 beds. So we have multiple ICUs, and the ICU where I'm typically at is the medical surgical ICU. So that ICU is, which I'll refer to it as MICU, that's usually what we call it. It's 44 beds, so it's a fairly large unit, and there's 3 physical therapists that cover the unit, and then I'm the lone OT that covers the unit. So in that sense, it's kind of cool because I get to experiment a lot, but at the same time, there's 44 beds and one of me, so I don't always get to see as many people as I would want to see. Being the medical surgical intensive care unit, we're also mainly the respiratory intensive care unit. So over the past year, it's looked a little different than when I first started there, and kind of how it is now when COVID came, because we were the primary COVID ICU, and then we had 3 additional makeshift ICUs when the second wave of COVID came. So that was also a little twist, because we had close to, I had close to like 60 people on caseload at a time. So that kind of started to shape why delirium was so important and why it was so important to manage it. So I'm going to start with just like a brief overview of like the ICU and OT, and then I'll dig deeper into delirium. But if you guys have questions about like anything that I say that I don't kind of go into detail with, you can pop them up there. Even if it's just like, what does that mean? Like a medical term or anything like that. So in the MICU, typically we have a lot of surgical patients, surgeries such as any type of ENT, or so nose, throat surgeries, lots of cancer surgeries, Whipples, which are pancreatic surgeries, lots of colon, any type of abdominal surgery, they usually come to us. We also have the more medical complex individuals. So for example, individuals that come in with respiratory failure that need the ventilator, individuals with asthma attacks who unfortunately require ventilator support, hypothermia at this time of year, those patients will come to us, patients found down at home. Sometimes we get like motor vehicle accidents and some like heart stuff, but we have an open heart ICU and a trauma neuro ICU that usually takes care of those, but we're usually the overflow since we're a larger unit. So with a lot of post-surgical patients, while they're in the ICU, they usually come to us and they go to the OR a few times. So they remain intubated the entire time, which means that they're on the ventilator. And depending on what types of surgeries they're getting, we begin to mobilize them, we begin to work with them, and kind of address the ABCDEF bundle of the ICU. So that bundle was put out by the Society of Critical Care to kind of look at the best way to manage patients who require like ICU level care. So the D in that ABCDEF bundle is delirium, and the E is early mobilization. So those are the 2 kind of focuses down in the ICU when I work with individuals. And while we're working with individuals who are intubated, they're typically on some type of sedative. So whether it be propofol, fentanyl, and being on those sedatives, it starts to create a bit of confusion for patients. So they're half awake, half asleep. There's beeping everywhere from alarms going off. And some of them may not even know that they're in the hospital because they had like an event at home where they had to emergently come in. So this is where delirium starts to brew, and delirium's like a catch-22 because in order to be extubated and have a successful extubation, so to get that ventilator tube out, it's you don't want to have delirium. That we want that gone. But the longer the tube's in, the more delirium increases. So that is kind of my battle down in the ICU. And what I try to do is to help minimize delirium for those patients. And then, so that's a lot of like the surgical medical patients. Then when COVID kind of started, we started to realize that most of our COVID patients were very delirious. So hyperactive delirium, where they're very agitated, acting out. We can't really decrease their sedation because it's just not safe. They're thrashing their head around and they have that tube in that goes down their throat into their trachea. So we were dealing with that. And then hypoactive delirium, which is where patients are more withdrawn. They may seem with it, but they don't necessarily know what's going on. They may be oriented, but they aren't able to really explain things. They have decreased attention, executive functioning, all that type of stuff. So when COVID started, we needed this. We were already kind of working on delirium, finding a way to track it, because delirium, when I started in the ICU, wasn't being tracked. So trying to identify it, track it, and then manage it. So my favorite tool that I use down there is, it's called the Cam Icu. So it's the confusion assessment method for the intensive care unit. And it's a very quick outcome measure that is very reliable and valid for determining whether someone has delirium. So I typically do that on all my patients. And then I try to come up with a plan from there. So that's just kind of how delirium became a big part of what I do down in the ICU. So I'll kind of go into just the day in the life, because that may help it seem more, keep it more organized. But you guys just interrupt me if you have any questions. So I typically come in to work that day, do a walk around the unit, and kind of just peek in rooms and see what people are looking like. So sometimes I just make note of like, okay, that room looks really good. They're sitting up, that person's awake and they have the tube in, so I want to work with them. And then I sit down, I look at all the evaluations and treatments I have that day. I try to kind of prioritize accordingly. In an 8-hour day, I usually only see 6 to 7 people, 8 if it's like an amazing day, but that doesn't always happen. So I try to pick the top individuals that would benefit the most and that are a like a top priority for the medical team. So when I say that, today there was an individual who, she is in our ICU with COVID, and she's been here for a few weeks. She had a C-section while she was here because she was 32 weeks pregnant when she came in. They had to do a C-section. They extubated her. So they got that tube out of her throat, but she wasn't necessarily responsive after they got the tube out. So that was kind of the top patient of the day, where they were trying to figure out if they would have to put the tube back in and re-intubate her, which they were trying to avoid, or what they would have to do. So that person was like #1 on my list, because I needed to go see where her cognition was at, see if she'd be appropriate for out of bed, try to engage her in any way, see if she has delirium, what we can kind of do to kind of start managing that delirium. So prioritizing patients. And then I just kind of walk around the unit and see, I always check with the nurses before I go in, just because it's the ICU. And I start to kind of just peek my head in, see who would be good. And that's kind of how the day goes. So it's very opportune in the ICU. You could chart review someone in the morning, and then 2 hours later they could code, which means that their heart rate kind of stops and a code team comes and does CPR and all that good stuff. So it's very opportune. You kind of have to build relationships down there with the nurses and the residents to kind of have them trust you working with their patients and getting them moving. So when I typically go see a patient, one of the first things I do is orientation type stuff. So I look at just the simple questions. Can you tell me your name? Can you tell me your birthday? Where are you? Why are you here? What time is it? What's the date? That type of stuff. I still ask patients that if they're intubated. I can get them to nod to me, give me thumbs up, thumbs down. Or if they're trached, like they have a tracheostomy that they're breathing out of, they can mouth to me, they can write. Some intubated patients will write for me. And then I usually always do the, where'd you go? Okay. I usually always do the Cam Icu then. So the Cam Icu is essentially a tool where you look at, just go into the room. Does this person have, are they altered? Are they from their original baseline? So almost everyone in the ICU is, so that's why I do it on everyone. Next, I look at, you have to look at their sedation. Are they, or do they have an altered conscious state? So I use a Ross scale for that. It essentially looks at how sedated they are, or how sleepy they are, or if they're overstimulated and very aggressive or not, or just agitated. And then we look at disorganized thinking and inattention. So inattention is kind of a really cool trick that I learned through the Cam Icu. I put 2 of my fingers in the patient's hands and I have them squeeze my hand every time I say a specific letter. So the Cam Icu has 2 phrases spelled out. You either spell out Casablanca or you spell out save a heart. And I do that with the patients. And I can also, even if they do well with it, I can see where their attention is at. I can see if they're focused, if they're looking around the room, if they're hitting all the right letters, if they're hitting not A, but every other letter. I can kind of see how they do with that. And then the disorganized thinking, there's a few questions I can ask them that are yes, no questions that are fairly basic questions that everyone should know if you're kind of in the right state of mind thinking. So one of the questions is, does a stone float on water? So that would be a no. So I can kind of see how they're thinking with that. And then if I see that they're CAM positive, I usually write it on the board in their room so that usually the residents will come in and they can see that, or the nurses, I'll go talk to them. And then I usually always go to the whiteboard in the room, even if the patient isn't delirious and I'm trying to prevent it. I make sure that the date's on the board. I make sure that like all the information on their communication board in the room. So it has like date, day of the week, who their nurse is, what rehab they're getting that day. I try to make sure that's all right. Then I try to open all the blinds in the room or turn on the lights if they don't want the blinds open, because one of the key parts of delirium management is just getting patients back into their routine. So even if they're acutely ill in the ICU, we still want them on a routine. So I want them awake during the day, asleep at night. That's the goal. It's a little tricky when patients come in and they're like night shift nurses or something, but those are the exceptions. We want them awake during the day, asleep at night. And then some of the more formal delirium management stuff will happen where if they're intubated, I kind of do different visual attention activities for them, like almost like looking at like I Spy in the room, like, can you find something green? And I'll like have I can watch their eyes, like look around, they're trying to problem solve, see where that stuff is. Sometimes we have them sit up at the edge of the bed, and then usually I co-treat with physical therapy for that when someone's intubated, just because of managing the endotracheal tube. So physical therapy will kind of be doing that early mobilization, and then while they're sitting up, I'll do activities with them. Most recently, I kind of did a case study that's part of my doctoral work with looking at like ADL engagement as a way to manage delirium. So keeping individuals in their routine, having them do the things that they typically do, having them socialize, kind of the things that we do as OTs, having them engage in meaningful activities, that's kind of what helps prevent and manage delirium. So sitting at the edge of the bed, we can work on like getting dressed, usually like upper body, because they usually have a lot of tubes and lines down below. So I'll do that. I'll do grooming with them. Hair care is a big thing in the ICU because if you don't do hair care, their hair will get matted, and no one wants to have to work through that, and no one wants to have to shave their heads after that. So us OTs try to save the day with hair care. At the end of the session, I usually set them up with, most recently, we got new TVs that have movies on, which is I'm a huge fan of because I can pick a movie for them and it's a plot that they have to follow. They usually helps them pass the time a little and helps them engage in something rather than them just like looking around the room or listening to the beeping that goes on in the ICU. So I'll throw a movie on for them, or if they need a lower stimulated environment, I'll put on like calmer music. I recently had our hospital network complete like a delirium drive for when COVID was really, when we had a large COVID population, we had drive out delirium. So I got a lot of like adult coloring books, puzzles, clipboards, things like that for our COVID patients who were intubated or trached for a significant period of time or on like high flow nasal cannula, because they were essentially living in the hospital or the ICU for 1 or 2 months, and delirium's kind of inevitable then. So trying to keep them engaged in things. So that was really successful, and we got a lot of activities for that. And it's nice to see the patients engage in that type of stuff because right now, like their families aren't allowed in the hospital. So sometimes families can help delirium because I educate the family a lot on things that would be beneficial, like how to help engage them safely, how to just talking to them can kind of sometimes help with managing delirium. But that's kind of the main goal of what I do when I go in and work with patients. With COVID, sometimes I'm a little more limited because the supplies I take in, we don't take out. So I have to make sure I can leave the stuff in there, or they can be wiped down with bleach or whatnot. And the goal would be with some of these patients who have delirium to see them for some form of like early mobilization session, but then to also see them for a session for cognition. So I try to balance that out with physical therapy. If possible, I have physical therapy go in and get them out of bed, into the chair, things like that. And then I go in and try to work on delirium. I can do delirium assessments on patients who have dementia. I mean, to an extent, like as long as it's not severe dementia, but just kind of like a mild cognitive impairment happening. Patients with strokes, I do it on. And yeah, that's kind of the main kind of stuff I do. I don't know how I am with time, but that's kind of what we do down there. And we're trying, our goal is, I'm trying to do a lot of research right now for delirium, just because it'd be really nice to have a second OT down there to help me because I can't always get around to all the patients. So trying to show that there's a need, trying to show that OTs we can help, and then hopefully getting a second OT down in the ICU.
Thank you. That was amazing. If anybody has any questions, feel free to unmute or put them in the chat. Yeah, go.
Me?
Yeah, go for it.
Oh, sorry, Emma. Hey, Lauren, so great. I was wondering if that was part of your doctoral work, like the research that you just mentioned. Did you incorporate that into your clinical doctorate?
Yeah, so I'm doing a case study right now for my doctorate. The research project that I'm doing, I'm actually doing a fairly large retrospective study on like every COVID patient we had in our first wave at every hospital within our network in the ICU. The hospital that I'm at is one of the only ones who initiates OT while patients are still on ventilators. So I thought that was kind of cool because in a sense, I can compare the patients who had OT and the ones that didn't. The only downside to that is we get the more severe patients. So we get the ECMO patients and a lot of the more advanced ones that need the paralytics, proning and all that. So that will affect things a little bit, but I still think it'd be cool to see what the results are from this.
We have some questions in the chat. Lily asked, do you often deal with empathy fatigue in the ICU?
That's a good question. Is empathy fatigue, are you referring to like with the staff to the patients?
I was thinking more so just like feeling burnt out from how much you're doing just as the only OT there. And especially during a pandemic, I can imagine that would be really hard for you to see all the delirium cases.
Yeah, that's a good question. During the 2 COVID waves that we had, it was definitely tough. And part of that wasn't necessarily from the patients having delirium, but some of our patients we would follow closely for 2 or 3 weeks and then have a very sudden kind of like downhill where they would need to go on life support, and it was just very shocking to see how downward they went. So that was tough. And we were working like 12-hour days during COVID, like less days, but 10 and 12-hour days to kind of reduce our exposure in a sense. So that was tough. And I definitely probably see it more with the nurses than I do myself, just because I get more of a break at least, and I don't have to be in the room with. So once in a while, I try to initiate FaceTiming family if I feel like the patient it'd be appropriate and they're able to engage, and they look like they're doing well. I don't want to have them FaceTime a family member and have them look like they're not doing well at all and scare the family. But nurses have to be in the rooms to do all that when patients aren't doing well. So we're lucky in a sense that we don't have to be there for that stuff, but it definitely can be tough.
Thank you. And then Rachel had a question, which I had the same question. You touched on it a little bit, but as the only OT on your floor, what do your hours look like? What time of day? How long? How do you fit that all in a day?
Yes. So I'm typically 8-hour days, 5 days a week. During COVID for a little bit, I was 3 versus 4 days a week, all like with 10, 12-hour days. Those days were actually pretty good because I could fit a lot of people in. But the 8-hour days are definitely better occupational balance and life work balance. So those are what my hours are. I get in a little later in the morning, like in between 7:30 and 8, just because if I get there too early, there is shift change for nurses, so they change at 7 a.m., 7 p.m. If I get there during shift change, I won't really be able to start jumping right in because it's just not fair to the nurses. They have to do meds and stuff like that. But that's kind of what the hours look like. Sometimes I stay late some days. Like yesterday, I stayed late the other day, but it all balances out. And we have like great managers and staff that if you stay late one day, they don't care if you leave early the next day, which helps with that fatigue down in the ICU. So that's nice.
Kiana has a question. Have you had any interactions with clients with delirium who don't primarily speak English? And if so, what has that been like?
That's a great question because yes, and it's very difficult at times. It's easier when I can get an in-person interpreter in the room, but when I have to use an iPad for someone who is experiencing delirium, it is typically I don't get the cam done. It's just you kind of can tell that they're having like delirium. Typically, it's hard to get their attention. With a lot of my intubated patients who have delirium, I'm like shouting at them, I'm screaming, I'm doing like sternal rubs and stuff to just get them to stay awake for a little. And when we have an iPad interpreter, I can't get the volume that loud. So it is very challenging. It's challenging to get patients to pay attention to a screen that has an interpreter. So if you ever have a delirious patient, an in-person interpreter is best. During COVID, we weren't allowed to have other people in the room, so we had to use iPads.
That was such a good question. One of the things I noticed too was just already all of this sort of out of the box ways of communicating, like hand squeezing and all that. So to try to transcend language on top of that, I can only imagine what sort of situations that might have brought up. Anna has another question. Since you don't know which patients on your floor you will see that day, how do you manage planning interventions and creating goals?
That's a great question. Typically, it's nice in a sense because most of the patients I see are are on the ventilator, so I can evaluate them, and I know they're going to be there for a little bit because they're usually, once they get off of ventilator support, they're usually in the ICU for at least a day or two until they go to the floor. So that helps because then I can at least evaluate them, see their plan, like understand where their baseline was, what goals. Their goals are almost always related to their baseline. Even if I don't know if the patient could ever get to their baseline, that's the goal in the ICU because it's at such the acute phase and they have a long road of rehab, whether it's in the hospital or going to rehab. I make their goals for their baseline. When someone scores CAM positive, I always make goals related to attention and like following commands. And recently, this kind of goes in with planning interventions. I actually had the opportunity to create a cognition clinical practice guideline that our entire hospital network uses with one of the speech therapists at my hospital. And we have created, right now it's only for COVID patients, but the goal is for every ICU patient to have this completed on. It's documentation that we do the Cam Icu, then we do the OLOG, which is an orientation. It's like a standardized orientation assessment outcome measure. And then we do the short blast test once they get to the floor. But we put this documentation in, and we have in all bold, needs cognitive intervention at this level of care. So we're hoping that triggers, okay, when they go to the floor, the therapists on the floor need to continue cognition and continue delirium management strategies. If they go to our acute rehab, this will trigger them, oh, they started out in the ICU, they had delirium, they may have after effects, we should do more formal testing. The acute rehab now has a clinical practice guideline, our outpatient home health and subacute rehabs do as well. So it's a lot of, I can only do a little bit in the ICU, but once they go to the floor, it's like communicating that to other members. If someone comes from the ICU and ends up getting right to acute rehab within a day, I usually try to contact the OTs that are there and let them know what their stay was like in a brief kind of summary, let them know what deficits they had, just so they're aware and they can continue the interventions of the deficits that I kind of saw.
That's amazing. Wow. Yeah. One thing that kept coming out to me was just there's so many moving parts in a hospital like that how do you keep it all straight? So that's amazing, really. Dr. Cozzolino has a question. How did you learn all that you needed to learn to feel comfortable in such a critical setting?
That's a great question. So I will say, my education at Ithaca, the basis of OT, that was so important for the ICU. Understanding to value a patient's autonomy, understanding the true benefit of meaningful occupations. As far as like splinting, I do splints down in the ICU. Like this week, I just had to do a splint for like a thumb replantation. Like they chopped it off, had to sew it back on, did a splint for them. So that type of stuff. The side that I really kind of had to feel comfortable with, I mean, it took time, but working with just all the lines and tubes, moving them around, understanding what they all are, like truly understanding ECMO, which is a form of life support. We do venous ECMO on the floor. So understanding that, understanding implications with that, understanding like troponin levels, hemoglobin levels, just different things, understanding like some of the respiratory illnesses. That took time. Also, I was very lucky because at my hospital, we do a 3-month orientation. So I went to all the other service lines. So trauma and the trauma neuro ICU, neuro and like we have a neuroscience ICU, we have an open heart unit, we have like a burn unit, we have all those. So really learning from other therapists too. But I will say, going back to the basics, actually applying your theory to your practice is way more beneficial than what you might think while you're in school right now. Like MOHO is so important, and so is, I use the CAWA model a lot to kind of guide practice and understand things. So that type of stuff, it will carry with you when you go out to work.
You kind of touched on goal setting already, but Matt had another question about sort of like how you document the goals. What does that look like? Do you have any sort of specific examples?
Yeah, so I document within like a flow sheet. So within that flow sheet, we kind of have goals built in. And I typically always do some form of functional balance goal, whether it's sitting or standing, related to like needing that for ADLs. So one goal may be like patient will demonstrate at least like fair functional standing balance needed for ADLs. As far as timeline, when patients are only on nasal cannula or room air, they typically have a timeline of like 2 weeks. Unless they're a COVID patient, then they're usually 3 weeks or 30 days. When someone's intubated, they usually have 3 weeks or 30 days timeline. So kind of their oxygen needs kind of dictate the time frame for the goals, but the goals usually always go back to their baseline. And I do typically do like a Cam Icu, like patient will score Cam Icu negative at least this many times, or will engage in the Cam Icu this many times, just so that doesn't get lost.
Great, thank you. And if anybody else has any questions, again, feel free to put in the chat or unmute yourself.
I have a question. Lauren, what advice would you give to our current students, or any, maybe even for alums who are on the call who might be interested in getting into this area, or just general advice?
Yeah. One piece of general advice I could give is to always be open to settings, because when I graduated and completed fieldwork, I was very set on wanting to do hand therapy, which I still love doing and I can kind of still do in the ICU, but I kind of fell into the opportunity of being able to be in the ICU, and it's my absolute favorite. So keeping an open mind with that. If you're interested in getting in to the ICU, I would definitely try to, as best as you can. I know fieldwork sites are hard, especially during COVID, but trying to find hospitals that have ICU programs. I know they're not as common, like a true intensive rehab program. But there are conferences, like Johns Hopkins throws a huge critical care rehabilitation conference, and they have a lot of great information. And even just going as a student, like they have like courses that are beneficial even if you've never worked in the ICU, but kind of dipping your feet in a little.
I have a question as well. Thank you, by the way, Lauren. This is such an informative and insightful presentation. You're so knowledgeable and such a, tremendous lifelong learner, and continuing on with research and contributing back. I've been really, really impressed. But my question, kind of like zooming out a little bit, is if you had to choose, like, what would you say in your setting with the work that you're doing right now? Like, what is your favorite part and what's your least favorite?
That's a good question. Yeah, I actually never even thought about my favorite part of being down there. My favorite part of being in the ICU is that there are some patients that we get to follow and see progress with. And there are some patients that we get to connect with in a way that like maybe nursing and like the medical team are like, oh, they're just not doing anything. And then we get to go in there and it may be like a 45-year-old like intubated patient, and we'll know that they like a certain type of music, and we'll like turn it on and see kind of try to like sit them up and stuff. And they'll be sitting at the edge of the bed and they'll just dance for us a little or things like that. And that is like the best part, is having a dance party with an intubated patient. Those always make my days and make everything else that can happen down there worth it. My least favorite part about being down there is definitely how quickly things can change with some of the patients we get connected to. And like being in the ICU, your role is not only therapy, but like therapy we document near the monitors. If we see that someone's heart rate is going in the 30s, 20s, we take the code cart and we take it to the room and make sure the nurses don't need an intubation tray or things like that. So that's my least favorite part, that and documentation, because there's a lot of documentation down there, vitals and all that kind of stuff that you might not have to do on the floor.
I have a question. Just listening, why, like, this is clearly so important that why do you think it isn't a bigger field within OT or just in healthcare settings in general?
Yeah, that's, I definitely think the research that I see out there is very new. A lot of the programs that I see building up at some larger hospitals are newer and have been done in like the past 5 years. I'm not entirely sure when the ABCDEF bundle came out, but I know when that came out, early mobilization was the big push, and that's how physical therapy kind of got in the ICU more. And then that kind of started to be like, okay, we're doing that, but now what are we doing for delirium besides medications? And I think OT is kind of starting to take a lead with that. But I think there's going to be a very big push in this after COVID, because almost every single COVID patient that I worked with has had delirium, and that was a big focus of why we couldn't get them extubated to an extent. And almost every patient who was delirious but met criteria to be extubated, almost all of them got re-intubated right after. So I think that with COVID and realizing that delirium was really starting to affect things, and COVID really kind of caused delirium in a lot of patients and prolonged hospital stays, I think that is going to be a bigger push. And I think that it's definitely other ICUs are going to start utilizing OTs more, or at least looking for ways to manage delirium. Also, within the past few years, the concept of a post-intensive care syndrome clinic came out. So a PICS clinic, which is patients who are in the ICU for an extended period of time. They have long-term deficits from delirium, immobilization, ICU-acquired weakness, all that type of stuff, PTSD and mental health concerns from being in the ICU. And these PICS clinics are starting to kind of like pop up here and there. And the growth of that is also growing OT, because PICS clinics are actually usually OT run. So, which I think is really cool, because we kind of look at the whole person. We can look at the mental health component, physical, cognitive, and like the socialization part of things.
Thank you. I see that Brianna has her hand raised. If you just want to unmute yourself.
Hey Lauren, it's Bree. I just had to jump in.
Hey.
Can you hear me?
Yes.
I had to jump in and say hi. I had to relate to your dancing story today, because I did the same thing with a patient to usher on the vent. And I relate
awesome.
to everything that you say. I'm also the only OT on my SICU unit, so I definitely, have an appreciation for everything you're saying and the need for delirium management in the ICU. So I appreciate you kind of putting this out there for us OTs down there. But I do have a question also. Do you feel like in your hospital that the nurses are able to carry over what you're implementing for your patients in terms of delirium management and like sleep wake cycles and, you know, lights
Yeah.
on, things like that?
So I want to say yes, but like where my hospital is, I can, when I drive home, like if I'm out somewhere and I drive home and it's like 6 p.m. and it's dark outside, I can look at the floor and I can see all the lights out on the unit. So not necessarily when we're not there, but that's definitely the goal, is to try to get them there.
Gotcha. Thanks.
Yeah, thanks, Bree.
Jess had a question in the chat about something you mentioned earlier. What exactly is the Abcdf bundle?
Yeah, so that bundle, it was kind of like a guideline put out by the Society of Critical Care that nursing staff should and residents should be using, or like any of the physicians down there should be using to guide practice for patients. So the A has to do with pain management, managing pain. B has to do with breathing and initiating like spontaneous breathing trials as soon as possible on the vent. C has to do with sedation, because for the longest time we were sedating all our patients to keep them calm while they're sick and keep them sleepy while they're sick, but that causes more problems. So adjusting sedation so it's just where it's safe for them, but it's not too much or too little. For example, if someone's on a paralytic, you have to have them on a sedative to keep them asleep. And then D's delirium, E is early mobilization, and F has to do with family engagement. So some hospitals actually really involve families, have like families start ICU diaries, which families write down kind of what goes on in the patient, their family member's hospital stay, which can be really beneficial for the patient once they're like recovered, to help them understand what they went through, to help like them understand, oh, when I woke up, like most patients are in restraint so that they don't pull out the tube. That's what those were. I remember that, things like that.
Very cool. Thank you for clarifying that. Kayleen has a question. Do you ever make adaptations to the environment focused on sensory components of the ICU? I can imagine that all the stimuli can be overwhelming for many people, and I'm curious if there are any strategies that you use.
Yes. Just this week I had a patient who required a low stimulation environment because if she was overstimulated, her heart rate would skyrocket to like the 200s, which is not good. So the main modification that I make has to do with just lighting and sound. Those are usually the only primary things I can change, unless sometimes family members will send stuff. And if that happens, I can change like the visual environment by having like pictures from family members, or for example, this patient was like a 22-year-old. And while she was 22, she still had like her parents had like her favorite pillow and a blanket. So having those things, because sometimes in the mix of things, they'll get kind of tossed in the corner of the room, making sure those things are out. Music is one of the primary things I try to use to mask like beeping, and have like either like a low stimulated environment with like, we have like a soundscape channel, and that is like really nice for patients. And then light, having like a dimmer light versus like just a hospital light on, or things like that.
Very cool. I think we have time for probably like one more question if anybody wants to hop in.
Question. You mentioned this a little like briefly before, but I was wondering if you could talk about like how you got into this field. Because I know you also mentioned like you were kind of going the hand therapist track. So just a little bit of like how you kind of got into it.
Yeah. So, yeah, kind of after all my clinicals, like field works, things like that, I wanted to go into hand therapy. But I really liked medical complexities. So the hospital where I work, they have a burn unit, and burn unit does a lot of like upper extremity hand kind of things while you're up there. So my goal was always to somehow get to the hospital to be able to get into the burn unit. But when I applied, the position was for like a float between medical surgical and then the medical surgical ICU. So I applied there and then fell in love with the ICU. And there's an OT that I kind of rotate with out of med surge. And then, well, we actually cover like the emergency room, and we have like an observation unit, and we do splinting in like the emergency department and things like that. And then we come into the ICU. But she kind of really loved that, and I really loved the ICU. So we kind of both stayed in our areas. And that's kind of how I got into being down there full time.
Great. Thank you so much. I think that's about all the time we have, but I just want to say thank you again so much for coming and sharing your story and all the twists and turns and ups and downs. We really appreciate it. I learned so much. This is an area I haven't heard too much about before, so valuable to me. Thank you. And just a reminder to all the participants that the transcript will be provided on the virtual OT Sakai site. Our next presentation will be next week, March 17th, with Erica Matskin about neurorehabilitation within military populations. So we hope to see you all there, and thank you all again so much for coming, and thank you, Lauren, for speaking with us, and have a great rest of your night, everybody.
Thank you
Yes,
so much for
thank
having me,
you.
everyone.
That was amazing, Lauren. Thank you.
Thank you. Really great to see you.
You too.
Amazing. Congratulations.
Thank you.
No. Hey, Bree. Hi, Sydney. Are you on
I
there?
know. Hi, guys.
Yay.